Hello, I'm Dr. Ann Bass. I'm a neurologist who has been treating multiple sclerosis for 29 years, currently with the Lone Star Neurology of San Antonio in Texas. Today, I'm here with two inspiring people living with RMS, Jamie and Caylee.
Hi, I'm Jamie-Lynn Sigler. I'm a mom, MS advocate, podcast host, and actor.
I'm Caylee. I'm an MS advocate and college volleyball coach. I love talking about KESIMPTA and helping others navigate life with their RMS.
Before we jump into our discussion, let me note that KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis in adults, including clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease. KESIMPTA is contraindicated in patients with active HBV infection or history of hypersensitivity to ofatumumab or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reactions have included anaphylaxis and angioedema. Warnings and precautions include infection, injection-related reactions, and hypersensitivity reactions, reduction in immunoglobulins, and fetal risk. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions. What would you say if I said, in the time we've been talking, either of you could have taken your dose of KESIMPTA for the month?
I believe you.
100%.
Is that why you prescribe it?
Well, there are a lot of reasons. I discuss with my patients a potential treatment's effectiveness, safety, and as we'll discuss, route of administration. Among the various options, subcutaneous, oral, infusion, there's much to consider. The fact that KESIMPTA is the only B-cell RMS treatment with powerful efficacy that can also be taken at home or on the go definitely factors into those shared decisions with my patients.
I'm curious, how do you typically broach the topic of self-injection? So when I switched to KESIMPTA, the idea didn't faze me. I was diagnosed over 20 years ago and have been poked and prodded, and I've become comfortable with a lot medically.
When I initially heard self-injection, I was a little bit wary. I wasn't sure if I would be able to do it, but once I learned about the specifics of the needle at the end of the pen, I was relieved that you never see it. I remember my neurologist saying that it's smaller than a pediatric needle.
When speaking with patients, I use the demo pen to illustrate how easy and simple I think it is to use the SensoReady pen. My conversation with patients typically goes something like this. I say, this is your treatment, and it will only take 1 minute once a month when you're ready to administer. The injection volume is low, 0.4 milliliters. You don't need to take any pre-medication or be monitored after. You can take this at home or on the go, since it can be kept at room temperature for up to 7 days. My demonstration actually takes longer than the 2 clicks you'll hear. The first, letting you know the injection has started. And the second, letting you know it's finished.
Wow, that sounds great.
It takes only 1 minute a month. I can even bring it to work if my treatment day falls on a weekday.
Before KESIMPTA, I was on an infusion, and on treatment days, I had to figure out transportation to the infusion center, school pickups, sports drop-offs, scheduling my podcast recordings and guest appearances. It was stressful, and it wasn't a me day.
And now?
Now I have more me time. Last month, I was even able to give myself treatment on vacation.
It's so comforting to know that treatment can fit into our routines. Dr. Bass, have you always been confident about self-administration?
In the past, I've heard from fellow healthcare professionals that in the back of their minds, they wonder about persistency or adherence. When a patient comes to the office for treatment, we know they're getting it. When they inject at home, there may be some degree of uncertainty.
That's fair, but I feel confident using the pen. I don't find it hard at all.
And that seems to be true for a lot of patients. A real-world survey shows that 90% of patients found the pen easy and simple to use.
That jives with my experience. But there's more to a treatment than how it's delivered. Do people tend to stay on KESIMPTA over time?
Excellent question, Jamie. In clinical trials, most patients that started KESIMPTA stay on KESIMPTA. In fact, 78% of patients, including those that switched from Aubagio to KESIMPTA, were still on treatment in the Alithio's trial at 6 years.
Well, I'm certainly sticking with KESIMPTA.
I also encourage my eligible patients to take advantage of Alongside KESIMPTA, which is the KESIMPTA Patient Support Program. Once a start form is submitted, Alongside aims to deliver seamless onboarding of patients. And patients can start today with samples.
Samples were a huge help to me. Getting my first dose right away helped me get on a schedule. I was so overwhelmed by my diagnosis, so starting KESIMPTA so quickly was encouraging.
That's so great to hear, Caylee.
That is huge because insurance can be such a, What happens if a patient can't afford KESIMPTA?
Jamie, that can be a real struggle for some patients. But coverage for KESIMPTA is better than ever. 90% of commercial patients are covered, with about 70% having first-line coverage. There's also copay support available for eligible commercial patients who may pay as little as $0 with a KESIMPTA Access card. Another option is the Alongside KESIMPTA Bridge program, which covers commercially insured patients for up to 12 months while coverage is being pursued.
Every bit of support goes a long way, so all of this means a lot to me.
I think that's a great point to end on. Jamie, Caylee, it's been great to get together and chat about your experiences with KESIMPTA. I wish you all the best. Thanks for joining. Please keep watching for the full important safety information and keep an eye out for more videos about KESIMPTA. In the meantime, you can learn more at KESIMPTAHCP.com.
Indication and important safety information. Indication. KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis, MS, to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. Important safety information. Contraindications. KESIMPTA is contraindicated in patients with active hepatitis B virus, HBV, infection, or history of hypersensitivity to ofatumumab, or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reactions have included anaphylaxis and angioedema. Warnings and precautions. Infections. Serious, including life-threatening or fatal, bacterial, fungal, and new or reactivated viral infections have been observed during and following completion of treatment with anti-CD20 B-cell depleting therapies. The overall rate of infections and serious infections in KESIMPTA-treated patients was similar to teriflunomide-treated patients, 51.6% versus 52.7%, and 2.5% versus 1.8% respectively. The most common infections reported by KESIMPTA-treated patients in relapsing MS, RMS, trials included upper respiratory tract infection, 39%, and urinary tract infection, 10%. Delay KESIMPTA administration in patients with an active infection until resolved. Consider the potential increased immunosuppressive effects when initiating KESIMPTA after an immunosuppressive therapy, or initiating an immunosuppressive therapy after KESIMPTA. Hepatitis B virus. Reactivation. No reports of HBV reactivation in patients with MS treated with KESIMPTA. However, HBV reactivation, in some cases resulting in fulminant hepatitis, hepatic failure, and death, has occurred in patients treated with ofatumumab at higher intravenous doses for chronic lymphocytic leukemia, CLL, than the recommended dose in MS and in patients treated with other anti-CD20 antibodies. Infection. KESIMPTA is contraindicated in patients with active hepatitis B disease. Fatal infections caused by HBV in patients who have not been previously infected have occurred in patients treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. Perform HBV screening in all patients before initiation of KESIMPTA. Patients who are negative for HBsAg and positive for HB core antibody, HBcAb+, or are carriers of HBV, HBsAg+, should consult liver disease experts before starting and during KESIMPTA treatment. Progressive multifocal leukoencephalopathy. No cases of progressive multifocal leukoencephalopathy, PML, have been reported for KESIMPTA in RMS clinical studies. However, PML resulting in death has occurred in patients being treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. In addition, JC virus infection resulting in PML has also been observed in patients treated with other anti-CD20 antibodies and other MS therapies. If PML is suspected, withhold KESIMPTA and perform an appropriate diagnostic evaluation. If PML is confirmed, KESIMPTA should be discontinued. Vaccinations. Administer all immunizations according to immunization guidelines. For live or live attenuated vaccines, at least 4 weeks, and whenever possible, at least 2 weeks prior to starting KESIMPTA for inactivated vaccines. The safety of immunization with live or live attenuated vaccines following KESIMPTA therapy has not been studied. Vaccination with live or live attenuated vaccines is not recommended during treatment and after discontinuation until B-cell repletion. Vaccination of infants born to mothers treated with KESIMPTA during pregnancy. For infants whose mother was treated with KESIMPTA during pregnancy, assess B-cell counts prior to administration of live or live attenuated vaccines. If the B-cell count has not recovered in the infant, do not administer the vaccine, as having depleted B-cells may pose an increased risk in these infants. Injection-related reactions and hypersensitivity reactions. KESIMPTA can result in systemic injection-related reactions and hypersensitivity reactions, which may be serious or life-threatening. Injection-related reactions with systemic symptoms occurred most commonly within 24 hours of the first injection, but were also observed with later injections. There were no life-threatening injection reactions in RMS clinical studies. In the post-marketing setting, additional systemic injection-related reactions and hypersensitivity reactions have been reported, including anaphylaxis, angioedema, pruritus, rash, urticaria, erythema, bronchospasm, throat irritation, oropharyngeal pain, dyspnea, pharyngeal or laryngeal edema, flushing, hypotension, dizziness, nausea, and tachycardia. Most cases were not serious and occurred with the first injection. Symptoms of systemic injection-related reactions may be clinically indistinguishable from acute hypersensitivity reactions. The first injection of KESIMPTA should be performed under the guidance of an appropriately trained healthcare professional. If systemic injection-related reactions occur, initiate appropriate therapy. Patients who experience symptoms of systemic injection-related reactions or hypersensitivity reactions with KESIMPTA should be instructed to seek immediate medical attention. If local injection-related reactions occur, symptomatic treatment is recommended. Reduction in immunoglobulins. As expected with any B-cell depleting therapy, decreased immunoglobulin levels were observed. Monitor the levels of quantitative serum immunoglobulins during treatment, especially in patients with opportunistic or recurrent infections and after discontinuation of therapy until B-cell repletion. Consider discontinuing KESIMPTA therapy if a patient with low immunoglobulins develops a serious opportunistic infection or recurrent infections, or if prolonged hypogammaglobulinemia requires treatment with intravenous immunoglobulins. Liver injury. Clinically significant liver injury, without findings of viral hepatitis, has been reported in the post-marketing setting. Signs of liver injury have occurred weeks to months after administration. Patients treated with KESIMPTA found to have an alanine aminotransferase or aspartate aminotransferase greater than 3 times the upper limit of normal, ULN, with serum total bilirubin greater than 2 times the ULN, are potentially at risk for severe drug-induced liver injury. Obtain liver function tests prior to initiating treatment. Monitor for signs and symptoms of hepatic injury during treatment, including new or worsening fatigue, anorexia, nausea, vomiting, right upper abdominal discomfort, dark urine, or jaundice. If symptoms of liver injury are reported, measure serum aminotransferases, alkaline phosphatase, and bilirubin levels. Discontinue KESIMPTA if liver injury is present and an alternative etiology is not identified. Fetal risk. Based on animal data, KESIMPTA can cause fetal harm due to B-cell lymphopenia and reduce antibody response in offspring exposed to KESIMPTA in utero. Transient peripheral B-cell depletion and lymphocytopenia have been reported in infants born to mothers exposed to other anti-CD20 B-cell depleting antibodies during pregnancy. Advise females of reproductive potential to use effective contraception while receiving KESIMPTA and for at least 6 months after the last dose. Most common adverse reactions. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions.